In this module of echocardiography in congenital heart diseases, we will discuss all about congenitally corrected transposition of great arteries. This lesion is associated with double discordance, that is atrioventricular as well as ventricular-arterial discordance. Corrected transposition of great arteries could be associated with ventricular septal defects, outflow tract obstructions, and rhythm disturbances. It's more common in the setting of situs solitus with dextrocardia. The clinical presentation is extremely varied, with a newborn baby presenting with heart failure due to severe tricuspid left AV valve regurgitation, and there can be an adult survivor who is totally asymptomatic. The unique complications of this particular anomaly includes progressive left AV valve regurgitation, progressive AV nodal disturbance with complete heart block, and progressive systemic right ventricular systolic dysfunction. In the echo evaluation of corrected TGA, we should notice the position of the heart, since many of the corrected transpositions will be associated with mesocardia or dextrocardia. There is an atrioventricular and ventricular-arterial discordance, and the ventricle is L-looped, which means the morphological right ventricle is located on the left side of the morphological left ventricle. The left atrioventricular valve is the tricuspid valve, and a lot of abnormalities in this tricuspid valve are very common. There will be varying degrees of left AV valve regurgitation. Because of ventricular arterial discordance, the pulmonary artery arises from the right-sided left ventricle, and the aorta arises from the left-sided right ventricle. Aorta is often left and anterior to the pulmonary artery and is described L malpost. There may be a presence of ventricular septal defect, left ventricular outflow tract obstruction, very rarely right ventricular outflow tract obstruction, and in some cases the systemic right ventricular function will be very depressed. Subxiphoid view in this patient with corrected transposition of great arteries demonstrates dextrocardia. The apex is facing towards the right side. Mesocardia or dextrocardia is more common in corrected transposition of great arteries. In this apical four-chamber view, we can appreciate the atrioventricular discordance. The right ventricle is connected to the left atrium, and the left ventricle is connected to the right atrium. We can notice that the trabeculated right ventricle is located on the left side. The tricuspid valve can be appreciated by the septal attachment of the caudal tissue. We can notice here the tricuspid valve with the caudal tissues attached to the interventricular septum. The right ventricle is not only trabeculated but also dilated with reduced right ventricular systolic contractility. We can notice that there are septal caudal attachments for the tricuspid valve to the interventricular septum. The tricuspid valve will have more apical attachment and the mitral valve will have more basal attachment. The mitral valve will not have any septophilic chordae, whereas the tricuspid valve chordae will be attached towards the interventricular septum. The atrioventricular valve attachment offsetting is very clearly seen when we magnify the region of the atrioventricular valve annulus. We can notice that the tricuspid valve is more apical in its attachment and the mitral valve is more basal in its attachment. To differentiate between a smooth left ventricle and the trabeculated right ventricle, we need to see the interventricular septum. The interventricular septum will have a smooth surface on the left ventricular side and a very coarse, rough surface on the right ventricular side. In some patients with corrected transposition of great arteries, the trabeculation of the left sided right ventricle can be more marked. The trabeculations can extend on to the entire right ventricular cavity and appear as if there is a non-compaction. The left atrioventricular valve in corrected transposition is morphologically tricuspid. We can see that very clearly on a 3D en-face view from the roof of left atrium. We can notice the dilated left atrial appendage shown as LAA. We can notice that the atrioventricular valve has got 3 leaflets. The one marked A is the anterior tricuspid leaflet. The one marked S is the septal tricuspid leaflet. The one marked P is the posterior tricuspid leaflet. We can notice that immediately anterior to the tricuspid valve, we are not having the aortic valve as in a normal heart, but the pulmonary valve. In a full volume loop, from the atrial view, we can appreciate the bicuspid mitral valve and the tricuspid tri-leaflet systemic AV valve. Contrary to a normal heart where the aorta is wedged between the two atrioventricular valves, which gives an aortomitral and aortotricuspid fibrous continuity. In corrected transposition of great arteries, the pulmonary valve is wedged between the tricuspid and the mitral valve, and so there is a mitral pulmonary and a tricuspid pulmonary fibrous continuity. On three-dimensional echocardiogram, when we see the left ventricular septal surface en face, we can appreciate the mitral valve, the smoothly trabeculated left ventricular septal surface, and the pulmonary valve. The mitral valve and pulmonary valve has got very close mitral pulmonary fibrous continuity. However, the aortic valve is displaced far more anteriorly, giving rise to a subaortic conus. Because of ventriculo-arterial discordance in corrected transposition of great arteries, the posterior pulmonary artery arises from the left ventricle and the anterior aorta arises from the right ventricle. The posterior great artery that arises from the morphological left ventricle has got a bifurcation into right and left pulmonary artery, and this will indicate that posterior great artery is the pulmonary artery. We can appreciate the mitral pulmonary fibrous continuity. The morphological left ventricle is seen on the right side, and the main pulmonary artery, which is dilated, is branching into the right and left pulmonary arteries. The aortic valve is not in fibrous continuity with any of the atrioventricular valves. There is a muscular subaortic conus. When we visualize both the great arteries, we can notice that there is a parallel outflow tract. Initially, we start seeing the main pulmonary artery, which is dilated, and on a leftward sweep, we see the ascending aorta. Both these great vessels course posteriorly as they ascend up, and these two outflow tracts are parallel to each other. On a color flow Doppler, we can notice that both the great arteries have an unobstructed outflow tracts and they course parallel to each other. On a transesophageal echocardiogram, we can notice that the pulmonary valve is in very close relation to the atrioventricular valve, and a well-formed subpulmonary infundibulum is absent, since the pulmonary artery is arising from the morphological left ventricle. However, the aortic valve, which is anterior, has got a well-formed subaortic conus, and is separated off from the atrioventricular valves. In this magnified view, we can appreciate the close relationship between the atrioventricular valve and the pulmonary valve annulus. On a three-dimensional echocardiogram, when we visualize the morphological systemic right ventricle from the apical portion, after cropping off the apex and the mid portion of the right ventricle, we can see the basal portions of the right ventricle where the tricuspid valve is attached. We notice that the ascending aorta is arising far more anteriorly from a subaortic conus. The anterior, posterior and septal tricuspid leaflets have been named A, P and S respectively. The left atrioventricular valve, which is the systemic atrioventricular valve, is tricuspid and is associated with large variations in character transposition of great arteries. The systemic atrioventricular valve is appreciated as tricuspid valve by its apical attachment compared to the mitral valve. There is an atrioventricular valve attachment offset with more basal placement of the mitral valve and more apical placement of the septal tricuspid leaflet. In some patients, this displacement can be more marked. In this example, we can notice that the septal tricuspid leaflet is attached almost around 12 millimeters below the level of attachment of the mitral valve. This abnormality of the left atrioventricular valve is described as an epsteinoid malformation of the left AV valve. In this patient with corrected transposition of great artery, the anterior tricuspid leaflet cord has got ruptured, resulting in excessive mobility and flail anterior tricuspid leaflet. There can be multiple different reasons for tricuspid regurgitations in patients with corrected transposition of great arteries. In this example, we can notice that there is a restricted mobility of the tricuspid valve leaflets caused by a dilated right ventricle and tethering of the right ventricle by the shortened cardopapillary apparatus. This tethering is caused by dilated right ventricle and right ventricular systolic dysfunction along with a congenital shortening of the subvalvular apparatus. In patients who have large inlet ventricular septal defects, in the setting of atrioventricular discordance, there can be considerable straddling of the left atrioventricular valve. We can notice the caudal structures of the left atrioventricular valve getting attached to the crest of the intraventricular septum and the margins of the inlet ventricular septal defect. The straddling of the left atrioventricular valve and the caudal attachment of the left atrioventricular valve to the margins of the inlet ventricular septal defect are more clearly appreciated in this transesophageal echocardiogram. In some of the corrected transposition of great arteries, there can be a prolapsing ATL with excessive mobility. Here we can find the anterior tricuspid leaflet has got a substantial prolapse causing a large regurgitant orifice. The severity of tricuspid valve regurgitation will vary in patients with corrected TGA. In this example, we can notice that the right ventricle and the left atrium are not dilated at all and there is no tricuspid regurgitation. In this apical view, we can notice a mild dilatation of the left atrium and morphological right ventricle and mild left AV valve regurgitation. Here there is a very severe left AV valve regurgitation causing a marked dilatation of the left atrium. Whenever there is a severe left AV valve regurgitation, there will be a large antegrade flow of blood from the left atrium into the right ventricle. Since the stroke volume gets combined along with this regurgitant volume, this will give a tricuspid inflow signal acceleration. Left atrium gets progressively more and more dilated in the presence of severe left AV valve regurgitation. Using a continuous wave Doppler, if we measure the tricuspid regurgitation jet's peak velocity, we can find the difference between the systemic systolic pressure and the peak right ventricular systolic velocity obtained by the continuous wave Doppler and derive the pressures of the left atrium. On a parasternal short axis view, we can appreciate that the aorta is left and anterior and the pulmonary artery is right and posterior. This is described as the L malpost aorta, or in short, the L post aorta. In the absence of outflow tract obstructions, the anterior aorta will be marginally smaller than the posterior pulmonary artery. We can notice the coronary arteries arising from the left and anterior aorta. On a subxifoid long axis view, we can notice the left-sided morphological right ventricle giving off the left and anterior aorta. Ventricular septal defect is a common association in corrected transposition of great arteries seen in about half of the patients. We can notice a large non-restrictive subpulmonary ventricular septal defect in this magnified apical four-chamber view. Subxifoid long axis view shows the mitral pulmonary fibrous continuity, the morphological left ventricle giving off the pulmonary artery, the smooth surface of the intraventricular septum on the LV side, and the coarse trabeculations of the intraventricular septum on the right ventricular side, and aorta is arising left and anterior from this morphological right ventricle. We can notice the presence of a large subarterial ventricular septal defect. The ventricular septal defect is located immediately below the pulmonary and the aortic annulus. In this patient, the conal septum was absent. On an apical view, we can appreciate the flow of blood on color Doppler from the morphological right systemic ventricle towards the pulmonary artery through the subpulmonary ventricular septal defect. This is an example of a large inlet ventricular septal defect with grade 1 straddling of the left atrioventricular valve and about 50% override of the left atrioventricular valve. In this inlet ventricular septal defect, since the tricuspid valve apparatus is attached with its caudal attachments to the margins of the ventricular septal defect, in systole, there is a restriction of the blood flow from the morphological right ventricle to the left ventricle. And this restriction is shown as a mosaic turbulence of the VSD jet. The restriction of the ventricular septal defect is caused by the septal attachment of the tricuspid valve apparatus. Sometimes the ventricular septal defects can be very restrictive. This is an example of a very restrictive perimembranous ventricular septal defect in a corrected transposition of great arteries. The anatomical size of the ventricular septal defect is only around 6 millimeter, and it can be compared to the large dilated pulmonary artery. Left ventricular outflow tract obstruction causing pulmonary stenosis can be seen in about 1/4 of the patients with corrected transposition of great arteries. It's more common with an associated ventricular septal defect, and isolated pulmonary stenosis is relatively less common. In this apical 4-chamber view, we can appreciate the accessory AV valve tissue from the left morphological tricuspid AV valve through the ventricular septal defect protruding into the left ventricular outflow tract and causing a subvalvular LVOT obstruction. Sometimes the left ventricular outflow tract obstruction can be caused by accessory AV valve tissue from the mitral valve, which cause a mitral regurgitation as well as a subvalvular pulmonary stenosis. If we interrogate the mitral regurgitation jet Doppler, we will get a rough estimate of the left ventricular systolic pressure. In some of the patients with left ventricular outflow tract obstruction, we will notice that the morphology of obstruction is due to annular narrowing. This is an example of a corrected transposition with an annular and valvular narrowing of the pulmonary outflow tract. Discrete subvalvular muscle bundles can also cause subvalvular left ventricular outflow tract obstructions. Left ventricular outflow tract gradients can even go up to 100 millimeters of mercury, and this will represent a severe pulmonary stenosis. Another example of left ventricular outflow tract obstruction in the setting of corrected transposition of great artery caused by a marked muscular hypertrophy from the septal wall in the region of left ventricular outflow tract. We can notice a discrete muscular bundle arising from the interventricular septum in the subvalvular pulmonary outflow tract. So the various reasons for left ventricular outflow tract obstruction in the setting of corrected transposition can be accessory mitral AV valve tissue which protrude into the left ventricular outflow tract, accessory tricuspid valve tissue that protrudes through the ventricular septal defect into the subvalvular left ventricular outflow tract, anomalous attachments of the mitral valve to the interventricular septum, discrete subvalvular muscle bundles in the left ventricular outflow tract, narrowed pulmonary valve annulus and doming pulmonary valve. All these can be acting as reasons of pulmonary stenosis in the setting of corrected transposition of great arteries. This is an example of how anomalous septal attachments of the mitral valve to the interventricular septum can lead to left ventricular outflow tract obstruction. Even though a normal mitral valve is septophobic and does not have any attachment to the interventricular septum at all, and mitral valve can have anomalous, abnormal septal cords which can get attached to the interventricular septum in the left ventricular outflow tract and cause a LVOT obstruction. This anomalous septal mitral valve cords are causing a substantial subvalvular LVOT obstruction in this magnified apical view. While left ventricular outflow tract obstruction can be seen in about 1/4 of the patients with corrected transposition of great arteries, obstruction to the right ventricular outflow tract or the systemic right ventricle is relatively rare in corrected transposition. we can see a thick subaortic conal muscle obstructing the right ventricular outflow tract in this magnified parasternal long axis view. The discrete infundibular or conal muscle in the subaortic conus is causing a tight narrowing of the subvalvar right ventricular outflow tract, and this causes a subaortic stenosis. On an apical view, we can notice the right ventricular outflow tract obstruction caused by a subvalvar conal muscle bundle. When there is a right ventricular outflow tract obstruction, the peak gradients can be assessed by using continuous wave Doppler. Right ventricle is the systemic ventricle in patients with corrected transposition. It's more trabeculated, and right ventricular systolic dysfunction can set in at any point of time in the course of corrected transposition in its natural history. When there is a very mild right ventricular systolic dysfunction, it will be appreciated on echocardiogram only as a subtle dilatation of the right ventricle in comparison to the left ventricle. However, as the RV systolic dysfunction progresses, there is progressively more and more dilatation of the right ventricle. In the presence of large ventricular septal defect, there can be a biventricular systolic dysfunction as well. We can appreciate that there is a dilatation of both the left and the right ventricle with poor contractility of both the ventricles. Aorta is often left and anterior in corrected transposition. The aortic root can be appreciated by the coronaries that arise from the aortic root. We can appreciate here that the left coronary artery is arising from the right facing sinus and is bifurcating into left anterior descending uncircumflex arteries. In this magnified parasternal short axis view, we can notice that the aorta and pulmonary annulus are more or less side by side. The aorta is lying on the left side and the pulmonary artery on the right side. We can also notice that both the right coronary and the left coronary arteries are arising from the anterior facing sinus. Even though both the left and right coronary arteries are arising from the anterior facing sinus, we can notice that they are located a little apart from each other. There is a distance of around 3 millimeters between the origins of the two coronary arteries. In the surgical management of corrected transposition of great arteries, a double switch operation will be performed, and it aims at recruiting the left ventricle as the systemic ventricle. As an initial stage, sometimes pulmonary artery banding will be done to retrain the left ventricle prior to a double switch operation. If there is a severe left atrioventricular valve regurgitation, it will either be repaired or replaced. VSD closure may be done with or without a double switch in patients with corrected transposition. Pulmonary artery band is a preparatory stage for left ventricular retraining before a double switch operation. We can appreciate from this subxiphoid long axial view the mitral pulmonary fibrous continuity, the dilated pulmonary root. A band has been placed in the main pulmonary artery, and the branch of the main pulmonary artery are seen. This banding is done to retrain the left ventricle and induce left ventricular hypertrophy before a double switch operation. We can notice the flow turbulence across the pulmonary artery band in this subxiphoid long axial view. On a parasternal short axis view, We can notice the anterior ascending aorta, posterior main pulmonary artery. The band is shown and the main pulmonary artery branches off into right and left pulmonary arteries. On an apical four-chamber view, we can appreciate the mid-main pulmonary artery tight banding, which is done as a preparatory stage before a double switch operation. To summarize, corrected transposition of great arteries is associated with double discordance, atrioventricular and ventricular arterial discordance. The morphological right ventricle, which sustains the systemic circulation, is more trabeculated and often will have a systolic ventricular dysfunction. The tricuspid valve and the mitral valves can be appreciated by the atrioventricular valve attachment offsetting, septal attachment of the tricuspid valve leaflet, and on three-dimensional echocardiogram by the number of leaflets. Ventricular septal defect may be seen in about half of the patients with corrected transposition of great arteries and can be seen in any location. Pulmonary stenosis can be caused by a variety of reasons, but subvalvular aortic stenosis is relatively rare in corrected transposition.